All right, a very good afternoon to all the ladies and gentlemen present over here, and a very warm welcome to all of you. I'm your virtual host, Diksha Rena, and it's my pleasure and privilege to welcome all of you to this eventful afternoon at Day 2 TOS Vision 2021, 6th Annual Virtual Conference of the Telangana Ophthalmological Society at Dr. S. Badrinath Hall. Ladies and gentlemen, to begin with the first session of the day on current management of Strabismus and Amblyopia, I would like to invite our esteemed chairpersons. I welcome Dr. Pradeep Sharma as the chairperson. As the co-chairperson, I would like to welcome Dr. B. Venkateshwar Rao. And as the moderator, I would like to welcome Dr. Asha Samadani. I would now like to hand over to Dr. Asha to please proceed. Over to you, Dr. Asha.
Thank you, ma'am. Just let me share my screen. Yeah, I'm more than privileged and excited to have this Strabismus panel with the Strabismus stalwarts. And I'm more than happy to tell you that I have been mentored by Dr. Pradeep Sharma. I'm taking the privilege to invite Dr. Pradeep Sharma for his first talk. For a brief introduction about Sir. Sir has done his MBBS and MD, both from Dr. R.P. Center AIMS, and he has done his fellowship from UCLA in 2001. He has been the author of this famous book, Strabismus Simplified, which you can see in the hands of almost every postgraduate student. So over to you, sir.
Thank you, Asha. It's always a pleasure to be, and you have been a wonderful moderator and host even earlier. It's a pleasure to see you again. So. Is it coming? Yeah.
Yes, sir.
So today I'm going to talk about the close encounters that we have with the third nerve. It's like the close encounters of the third kind, which are always having a challenging thing for us. Because the third nerve is one of the most challenging problems in strabismus. It affects us with the motility problems, with vision problems, with ptosis, with pupils, which may be sometimes autonomic, sometimes they are spared, sometimes involved, and then of course the aberrant innervation problems. So it is something which has many variations of presentations. The important considerations that we should keep in mind are that because the third nerve supplies all the extraocular muscles except the lateral rectus and superior oblique. And mind you, it also supplies the LPS, the sphincter and the ciliary muscle in addition to the other 6 muscles that we normally talk about. Secondly, the variations are there because if it's a nuclear involvement or a fascicular involvement or an orbital division involvement, the presentation is different. Again, when the cause is different, it has a different presentation. Ischemic neuropathies spare the pupils in 70% of the cases. Then it may be partial because it is such a big gamut of presentation. It may recover partially and it may have aberrant regenerations. It may also have associated neurological deficits to cater to. Now, when we have a case of third nerve palsy, we should investigate for the cause. And primarily, we can put them into 2 categories. One are the vascular and ischemic causes, in which may be due to hypertension, diabetes mellitus, coronary artery problems, cardiac deficiency problems, or CVAs or vasculitis. We talked about the 70% of the ischemic causes are pupil sparing. But remember, if it's an incomplete third nerve palsy, that too may be a pupil sparing initially. So don't be beguiled by the fact that if it's a pupil sparing, it is only going to be an ischemic thing. And 30% of the ischemic lesions can also involve pupil too. So both ways you have to keep that in mind. The other group of conditions would be neurologic tumors or aneurysms or trauma. Now, if there are pupil sparing cases, how do we investigate? As I said, we look for the ischemic causes. And in addition to hypertension, diabetes, and heart problems, we also investigate for hyperlipidemia and also hyperhomocystinemia. Observe these cases for delayed pupillary involvement if there is a pupil sparing, because it may get involved if it was an incomplete lesion. Recovery usually begins in these ischemic lesions in 6 weeks' time, and it may completely recover by 3 months. Now, if there is no recovery happening, in a few weeks, and or the pupil is dilating, getting involved, or there are other neurological conditions which are now coming, or there is an aberrant regeneration, or there is a progression of the palsy, do not hesitate to do an imaging. We need to do an immediate MRI or MRA. If the pupil is involved and imaging is negative, then we may also think about doing a lumbar puncture study. Now, the aneurysms of the posterior communicating artery can be causing a third nerve palsy. So whenever you have a case in which the pupil is involved and MRI is to be done, as I said, in cases if there is a pupil sparing, even if it's sparing in less than 50 years old people, incomplete nerve palsies, as I said again, children under 10 years, aberrant regenerations, and those which are not improving in 3 months' time, you need to think about imaging again. How do we manage these cases? After establishing a diagnosis, and we see that if it's an ischemic lesion, it may recover, and we may wait for that period. If the person wants an early redressal, we may think about giving injection Botox in the medial rectus. Otherwise, we can advise him to just keep a patch for the time being and then wait for the recovery. If it's a neurologic condition like a tumor, aneurysm, or trauma, the case has to be referred to the neurosurgeon. If it's an aneurysm, then maybe the neuroradiologist, interventional neuroradiologist may take care of it. Usually, the recovery may happen in these cases, and we need to watch for 6, 9, or even 12 months if there is some sign of recovery happening in our 2-monthly follow-up. Crutch glasses will have to be given for cases which are having ptosis. Surgery is the final answer for cases which are not resolving. So as I told about crutch glasses. Now in third nerve palsy, we have to have realistic goals of surgery. Correction of deviations in primary position and down gaze is the prime area of our interest. So that may have to be done at the first, and we need to explain or counsel the patient that it may not be possible to correct the diplopia in all the other gazes. The limitation of movements may still remain in other positions or gazes. Enough time needs to be allowed for recovery in all these cases. So surgical options we can divide into 3 categories: the maximal recession, resection, or instead of resection, sometimes plication of the medial rectus may be done in the ipsilateral eye. Sometimes we may do R&R in the opposite eye. The other set of surgical options would be recession or posterior fixation of muscles in the other eye to create a fixation duress to improve the binocular fields of vision. In the third set of surgical options are transposition of muscles as required in an individual case. Now we case by case will take. Now this case has a preoperative deviation which is crossing the midline, although there is an exo. So such a case we can afford to do an R&R or a recession and plication. So recession, maximal recession of lateral rectus as per required for the FDT, and a medial rectus resection or a plication is done to improve the situation in most of the position or gazes of eye positions. The weakening procedures, sometimes we may resort to an adjustable recession, especially when we are having a diplopia which is small angle deviation. Now, the new kid on the block for resection is plication, as I said. Now, this is another case which I would like to show you. It has an acquired partial third nerve palsy involving mainly the inferior division. And in this case, you can see that the problem is in the down gaze maximally, and especially in the dextro depression. So as you have seen with the red circle, we need to improve the exo, not only in the primary position, but also to improve the down gazes as it is more important. So what we did was did an FDT for the lateral rectus and superior rectus, which was fortunately free. So what I did was a modified inverse NAP procedure in the right eye. The right lateral rectus was reinserted at the right inferior rectus side without any recession, and the medial rectus on the right side was resected by 6 millimeters and again reinserted at inferior rectus. So this is a modified inverse NAP procedure. And as you can see, the exo deviation in primary position has corrected, as well as the dextro depression has improved because of our correction. Now, another case which has presented us is little different. It has a large exotropia. It's a complete third nerve palsy involving the ptosis also. Now, in this case, there was an improvement of ptosis on the looking up. So I did a contralateral superior rectus recession along with a lateral rectus on the right side, the ipsilateral eye, split, Y-split, and position on the medial rectus side. And you can see that improves the adduction as well as the exo in the primary position. And the hypertropia or the right hypotropia has also improved because of the contralateral superrectus recession. This is another case in which there was a large exotropia. The FDT is very tight. Now, when the FDT is tight, you can't do a lateral rectus Y-split and medial positioning. So what we can do is a periosteal anchoring of the lateral rectus, because supramaximal recessions also do not yield as much correction for the adduction. So in this case, the periosteal anchoring of the lateral rectus was done to take away the lateral rectus altogether, and the medial rectus was resected 8 millimeters. Nowadays, I would do application instead of resection. Another case in which there is a 90 prisms of exo, and the FDT for lateral rectus is very, very tight. In such a case, again, what we have done is lateral rectus recession, supramaximal or a periosteal anchoring of the lateral rectus, but the anchoring of the globe has been done to achieve the exo correction in primary position. Now, this is something which we have done from the DCR approach earlier, but nowadays we prefer to do it from the pre-caruncular approach. When there are aberrant regenerations of the lid in the right third nerve, we have to individually see the case. Now, this case, if you see carefully, there is an aberrant innervation to the lid, which causes a lid retraction in adduction and on looking down. But fortunately, the exo has got corrected well. So we do not have to do any surgery for the horizontal recti. And in this case, only have to counsel for the aberrant lid, for which a oculoplasty surgeon may do the justice. Sometimes we can take advantage of the aberrant regeneration in the lid by operating on the other eye. And in this case, that is what we had to do because there was a ipsilateral exotropia. And in this case, we have done a contralateral lateral rectus recession and the medial rectus resection. And as you can see, this has corrected the lid as well as the positions of the in the 9 gazes. Sometimes you have just the involvement of the medial rectus, like in this congenital medial rectus aplasia in bilateral, in this case, it was almost like 100 prism diopters of exotropia and hardly any adduction possible preoperatively. In this case, lateral rectus has to be recessed because it is tight. And if you do the lateral rectus recession, you do not have the medial rectus there altogether. What do? You may do a periosteal anchoring, or in this case, because the superior rectus and the inferior rectus were having some innervation, I chose to do a modified Nishida to improve the adduction. And you can see the very heartening results of improving the adduction as well as correcting the exotropia satisfactorily. So modified Nishida's procedure for case in which there is an adduction deficiency, but the superior and the inferior recti are working, may be done in cases of adduction hypoplasias. Superior oblique nowadays we don't do because it yields a very complicated deviations in down gazes. So it is preferred not to touch this. Congenital cranial disinnervation disorders of the third nerve, that means of the third kind, can also affect us in the form of congenital fibrosis extraocular muscles, synergistic divergence, or what we have described as the synergistic innervational downshoot syndrome, or the Marcus-Gunn jaw winking phenomena. So in these cases, if you do an imaging, you can confirm the missing nerves and the hypoplastic nuclei. A child having a synergistic divergence, we have done a lateral rectus to MR transposition, and this yields very good results in these cases. In fact, it seems that this is an ideal procedure for a synergistic divergence as it improves adduction appropriately. So you can confirm these by doing a high definition imaging to confirm the synergistic divergence and correct this as a targeted strabismus surgery. I would just like to end my talk to give a statement that we should be a squintellectual and individualize our cases so that we can spread sight and happiness for kids the world across to, as far as possible, maintain the stereopsis and restore the loss. Thank you very much for giving me this opportunity. Thanks.
Thank you, sir. That's such a wonderful talk. Everything regarding the third nerve palsy has been covered from basic till the advanced surgeries. It's been a pleasure hearing to you again, sir. I would like to take the pleasure to invite our next speaker, Dr. B. Venkateshwar Rao. Sir has done his residency training and fellowship in Strabismus and Neuroophthalmology under Dr. Prem Prakash from Dr. R.P. Center Ames. He has done the prestigious AAPOS fellowship under Professor Helveston from Indiana University. He has headed the department at LVPI till 2006. Currently, he is the director of Shraddha Center, Hyderabad. Over to you, sir.
Thank you, Dr. Asha. Yeah, thank you, Dr. Asha, and thank you, Dr. Pradishna, for a wonderful talk. As usual, the third nerve palsy, the management, quite interesting. So I'm going to go from third nerve palsy to the most common form of strabismus, what you see across in Asia and most common in India, the management of intermittent exotropia. It's the most common form of binocular vision dysfunction, and it affects about 1% of the population globally. It affects both children and adults. Usually, it's the Western world, the esotropia is more common versus in Asians. In Asians, exotropia is more common. And the onset is usually in childhood. It usually starts between 2 to 3 years of age, but sometimes it could start even in the first 1 year itself. Usually, the children do not have any symptoms. The deviation gets manifested or worse whenever the child is tired or sick or distressed or daydreaming, or when she gets up from the sleep and things like that. And sometimes, these children typically have a monocular closure whenever they go into bright sunlight, they tend to close one eye. And that's one of the typical symptoms you see in the children with intermittent exotropia. Now, here is a child, this child was in the first 1 year itself. And you see this child just breaks for distance on just a cover test. And, he goes into exodeviation and then he controls again. So it doesn't mean that it's not seen in earlier, but generally it's seen between 2 to 3 years. Now this is an older child. You can see again intermittent exotropia breaking spontaneously for distance. Now usually these children, the amblyopia is extremely uncommon, and it can be present if they have anisometropia, uncorrected anisometropic error in one of the eye can give rise to an amblyopia. And usually they have good binocular vision and stereopsis for near. Whenever they manifest for distance, they have suppression. And then sometimes if it's a large angle exotropia, they tend to have a panoramic visual field. And few children or few of them can complain of seeing double vision, but most of the times it's a suppression where whenever the eye deviates out, there's a suppression which prevents them from seeing double vision. Now coming to the control, how do you quantify the control? This is essential for the management of intermittent exotropia. Now, good control, fair, and the poor control. The good control is whenever it breaks on cover test, but it resumes fusion without a blink or without refixation. That's a good control. Now, it breaks, but it resumes fixation after a blink. It's about fair control. A poor control is it spontaneously breaks without even disrupting the fusion. Whenever the child sits in your examination room and when he looks for distance, the eyes are out. That usually means it's a poor control. There are scores which are available to assess the control, the Newcastle and the Mayo scores. And basically, it's the same thing, home control and the clinic control. You look at the way how the control is, and then basically kind of quantify the control and then start managing these children. Now, coming to the glasses, some of the exotropic patients, it's as usual in all strabismus patients, refraction is a key thing. A cyclopentulate refraction has to be done in a proper correction. We correct myopia, anisometropia, high hyperopia, and astigmatism. Needs to be corrected in these children prior to managing them surgically. Low hypermetropia correction generally is not recommended because it tends to break the fusional convergence because they tend to not accommodate, and then the fusional convergence goes away, and then it will worsen the control in them. So low hyperopic correction generally we do not give. Now coming to the workup of intermittent exotropia, the patch test, the diagnostic occlusion test, which we do for 1 hour, and then we check the deviations, and then the +3 lenses basically for high AC by ratio to uncover the deviation for the near, and lateral incompetence also has to be taken into account, and then the far distant measurement. The lateral gaze incompetence basically because though it's questionable, but sometimes it can cause overcorrection on the side gazes, and if you don't really look into this lateral gaze incompetence. Greater than 50% of reduction in the side gaze measurement versus the primary gaze warrants an asymmetric kind of a recession. Less than 10 prism diopters generally can be ignored, and How you hold the prism is also crucial in this lateral gaze measurements. So the prism has to be held over the adducted eye with the posterior face of perpendicular to the line of the side to prevent any lateral incompetence, which was well elucidated by Mike Repka and his group. Now, as you all know, the types of exotropia, the basic, the divergent excess, and the convergent insufficiency. The divergent excess is the most common one, which has got, again, two types, the pseudo and true. We'll just go over fast. The basic type is the distance on the near deviation is pretty much equal or within 10 prism diopters. They have normal ductions, they have normal near point of convergence, and the target angle is pretty much, you know what it is, the angle for distance. The divergent excess is the most common one. 2/3 of the patients with intermittent exotropia have divergent excess. Generally, the distance is more than near deviation by more than 10 prism diopters. And it's two types, the true divergent excess and the pseudo divergent excess. And the patch test is required to differentiate between both these types. And a +3 test is also needed to rule out the high AC by A. Generally, we patch for 1 hour and then measure the deviation for distant and near. And while you're measuring the deviation, when you remove the patch, do not allow the patient to re-establish the fusion. So you need to occlude one eye, remove the patch, put the prism in front of the eye, and then do alternate cover test. Momentary opening of both eyes will re-establish fusion and your patch test will go waste. So the prolonged occlusion generally suspends the fusional tonic convergence and it's unmasks the deviation for near. So the true divergent excess is even after a patch test, if the distant deviation is still more than 10 prism diopters, then it's a true divergent excess. And at the same time, high AC by A ratio has to be ruled out. And after doing a +3 near add in front of the child, and then see the deviations. So the deviation, if it doesn't build up closer to the distant deviation, then it's not high AC by A. And then the reason why high AC by A needs to be taken into account is if these patients, they have deviations which are masked for near because of high AC by A, and you don't take this into consideration and you operate for the distant angle, you land up with a consecutive esotropia for near, and it's not a good outcome. Now, the true divergent excess, we know this is the post-occlusion, 30 for distance and near for 20 from here, and you know the target angle is in between both of them. The simulated divergent excess after the patch, the near deviation builds up to the distance, so that's pretty much, you know, what's the target angle is there in the pseudo divergent excess. So the distance and near discrepancy is must, you know, so this needs to be taken into account by doing this. Sometimes you could do a rapid prism adaptation at the near, which can give you uncover the deviation for near. But most of the times we do 1 hour occlusion patch test prior to checking the deviations prior to the surgery. As I already told you, the high AC by A ratio is a potential marker for overcorrection. So we need to kind of check the deviations with +3 lenses for near after doing an occlusion test. And then this is one thing which you have to see. The patients who have high AC by A with intermittent XT, they have a ultra near esotropia. Whenever you check at a deviation at less than near, you know, your 1/3 of meter, and you see them having esophoric, that means that they have a high AC by A ratio. Now, the convergent insufficiency types are the ones which are the deviations are more for near than for distance. The pure convergent insufficiency, ortho for distance, near deviation, NPC remote, these are the ones who respond well to the convergent exercises, the fusional exercises, the pencil push-ups, and then the prisms, and surgery is the last resort in them. The other entity is poor convergence, where you have a near deviation is much more than the distant deviation. This is the convergent insufficiency type of intermittent exotropia. This requires a surgical correction, and convergent exercises do not help in them. So you have to do a surgical correction and then probably later on do a convergent exercises. And here probably we will do a resection, a monocular R&R in these patients because they have a near deviation more than for distance. Now, intermittent exotropia, do they progress? There is a kind of confusion in the literature. Von Uden series has shown that they worsen over a period of time. Some have shown they do not, but then it can vary a lot. So documentation needs to be required. Multiple examination needs to be done. And then, of course, the control over a period of time, the control worsens and the more and more noticeability is there, but the angle, does it increase over a period of time? That needs to be kind of documented over a period of examinations. Now, indications for the surgical treatment is loss of control, progression of loss of control, increase in size of angle of exotropia, astronopic symptoms for near. Minimum angle of deviation should be at least 15 prism diopters for a surgical correction. And even sometimes the patient or the parent wishes to get the eyes aligned, even if they have very good control, but the deviation has to be at least more than 15 prism diopters. Now, what's the timing for the surgery? Best operated at 4 years of age. The best for intermittent exotropia surgery. But having said that, earlier than 4 years, we still do in some of the patients who have poor control for distance, where the noticeability is so much that you can do sometimes earlier than 4 years, but usually 4 years and after is the best operated time for this surgery. And looking at the review of the literature, the most preferred procedure is the bilateral lateral rectus recession. That's the most favored surgical modality. Some do favor non-surgical modalities, but most of us do surgical modality as a treatment of choice for intermittent exotropia. Now, what's the surgical goal? We need to kind of get a small overcorrection, which is desirable in smaller children. That could be anywhere between 5 to 20 prism diopters, depending on various authors have done. In my hands, we go about 10 to 15 prism diopters of overcorrection in the initial postoperative period. It's been shown that if they're day one, if these children are straight, they tend to drift out over a period of time. On the first day, you create a small angle esotropia over 10 to 15 prism diopters. The weakened lateral muscle tend to kind of taken up the slack and pull the eyes out over a period of time. Now, this is a typical patient of intermittent exotropia. Post-surgery, have a small micro-ESO here. And then parents have to be told that, the eyes will become little inward. And most of the time, they will be little inward from what they were before. And they also complain of double vision. So the parents have to be told that these two things are expected post-operatively at day one, so that the parents do know exactly what they basically are looking at. Now, for a successful alignment to within 10 prism diopters of orthotropia, 4 less than 10 prism diopters, and absence of monocular closure, and so on and so forth. And there are tables which are there, doses which are there in the textbooks from the EPO survey and the Marshall Parks. And for the beginners, these are the tables which they can follow, and then they build their own numbers. Now here you see the success rate, about not very sobering success rate. This is long-term success rates beyond 10 years, but the initial success rates are good. Actually, we did a small study in the first 1 year with a very good success rate. But however, over a period of time, the success rate in intermittent exotropia tends to wane off with the recurrence of the problem in them. But then you need to counsel the parents that they may require a second operation as they grow up. In our series, we generally aim for 10 to 15 prism diopters of overcorrection. Any oblique muscle dysfunction needs to be tackled at the same time. The A and V patterns are to be tackled, otherwise your surgery will fail. And so these are just the pictures to show you the V pattern and the results. The surgical results are good for intermittent XT, basic and divergent, but convergent insufficiency, the results are not so good. The results are poor, but of course, over a period of time, you need to kind of look at them. Now, this thing is crucial, because surgery less than 4 years is reserved only for cases where there is a rapid loss of control, because there's a great chance that you could create a monofixation kind of a type of secondary esotropia, and these children can go into amblyopia and lose the stereopsis if you start operating earlier than 4 years. But having said that, the caveat is, if the control is poor and if you can get a good angle of deviation, you could still operate less than 4 years of age. So I think because of the lack of time, I think I'm just going to end up. So that's in a nutshell the management of intermittent exotropia. Thank you very much for the patient hearing.
Thank you so much, sir. You covered such a vast topic in such a small time. And thank you for highlighting the key points. Because of the constraint of time, we may have the discussion of all the talks when
Sure.
finish the talks, sir. I would like to invite our next speaker, Dr. Meenakshi Swaminathan. Dr. Meenakshi Swaminathan is currently working at Shankar Netralaya, Chennai. She has been a part of ICO and also WSPOS, and she has been actively involved in teaching. She enjoys teaching fellows and training residents. Over to you, ma'am.
Thank you so much, Dr. Asha, and thank you to TOS team and Dr. Santosh for this invitation.
And can you make it presentation mode full?
Pardon?
The presentation mode, full scale.
Yes, I am going to. I'm just chatting. so, so this I thought, in keeping with the theme of the conference, which is on technology. So I thought I will talk about what are the recent advances in amblyopia treatment using newer technology. See, some may say from 800 AD to now, when Tabit ibn Qurra in Baghdad suggested occlusion as a treatment for amblyopia, we are still doing the same now in 2021. Is it really the case? Well, not really. So let's look at what else we have up there. So we are going to have, well, occlusion works for all the regular amblyopes, the young kids with, strabismic and anisometropic, etc. But we do have these case scenarios like 23-year-old engineer diagnosed recently as anisometropic amblyopia, or an 8-year-old who is intolerant to atropine and cannot patch due to evening tuition and tennis classes. So we have to look at what else we have to offer to our patients. So restoring cortical plasticity and reducing interocular suppression has received considerable attention as a therapeutic strategy for amblyopia. And also there has been this recent times talk about why only focus on vision. Why not focus on binocularity, even if the vision is slightly subnormal, as the endpoint? So from that comes all the newer treatments. So first we have a set of treatments called behavioral treatments. Really, what are the behavioral treatments? So we look at some examples. The first one is perceptual learning, and it comes under the market name Revital Vision. It's a process whereby practicing certain visual tasks leads to improvement in visual performance. It's a non-invasive software-based therapy in which you use Gabor patches, which are the target for visual training. And it seems to facilitate neural connections at the cortical level. What are these Gabor patches? Let's look at what these exactly are, what Gabor patches look like. Now, Revital Vision not only helps in improving contrast sensitivity and visual acuity, but the effect seems to be sustained. Now, Gabor patches basically match the shape of the receptive field in the visual cortex and hence activates efficiency. Some people are wondering, is it the same as the CAM stimulator of the yesteryear? No, CAM is more passive, whereas perceptual learning is more active and prolonged. So what do we have as evidence for this? There is an ongoing trial called amblyopia treatment through perceptual training in children called AMPEL in 4 to 8-year-olds from the University of Basel. And this is, or Basel, and it's going to come out in 2021. But recently, earlier this year, there was an efficacy of perceptual learning-based vision training as an adjuvant to occlusion therapy, which came out of Spain, which was a pilot study, which said PL showed promise. All right. Now, let's move on. What about I know you are wondering, is this really available in India? Yes, it is. Revital Vision is available in India, and it is distributed by Encarta Pharma. I have no financial things to declare. And so it is available in India if you wish to use it for your refractory amblyopes. What about video gaming? Really, it is playing action and non-action video games with the better eye occluded. Again, it works on the principle of inducing cortical plasticity, and the video games appear to induce a reduction of noise and increase in sampling efficiency. You must be familiar with Dig Rush, which was the first prescription gaming to be approved by the FDA in the United States. And if you open and search for lazy eye apps, you find many, many on the net, but several of these are actually just games to keep your amblyopic child engaged. It is worth a try, but has addiction potential. And there is an article in 2017 JPOS from RP Center, which looked at adjunct to occlusion in anisometropic amblyopia and showed it was a useful adjunct. Okay, next from perceptual learning, we move to dichoptic training. So we have the software, which many are familiar with now, called Binocs. It's a novel cloud-based comprehensive binocular vision assessment and management software. And this is what is used for dioptic amblyopia therapy. Now, actually, the Binox has several modes. It has a diagnostic mode and has got a therapeutic mode. Now, we are more interested in this, and that, in particularly the dioptic amblyopia therapy mode. So what basically happens in Binox therapy is the patient uses an anaglyph for playing the games. So anaglyph means the right and left side have different color goggles. Color saturation of the fellow eye is kept low to facilitate binocular summation. Size and speed of the target improves based on the performance. It's effective for anisometropic amblyopia and strabismic amblyopia as well if the deviation is really small. That's what a Binox screen looks like, in which you can adjust the color of saturation, you can adjust the amblyopic eye selection, near visual acuity of both the eyes. And they have different games. There's a Super Ball, Super Car, Super Mare, and fusion convergence and divergence exercise with RDS targets can also be incorporated once the interocular suppression is removed. So it's worth a try, especially because focus is now on binocular vision. Dioptic stimuli are available in many institutes. Many institutes have access to Binox software. There are many studies from this group in Dallas, headed by Eileen Birch, and I encourage you to look through them. We move to one more technology, which is virtual reality, marketed under the name REMMED. And REMMED, again, is virtual reality plus dioptic-based game therapy. And they have many modes: anti-suppression, fusion, and convergence therapy. The nice thing about this is the patient's performance can be monitored with the help of a tablet by the therapist. There are 7 different games with different levels of training, which can keep the patient engaged and can also train patients with strabismic amblyopia, because you can neutralize the deviation with prisms. That's what a REMMED screen looks like. You can do monocular therapy, change contrast, brightness, and as I said, virtual prisms. Look for suppression check during training. And there are different targets available for the higher order of binocular vision, such as simultaneous perception and fusion. So in a binocular percept, this is what a screen looks like. And in the VR, when the child starts using the eyes together, then the rabbit and the carrot is all visible, and then the game can go on. Alternative therapies are, some more are available, but we'll just quickly run through those. You have the liquid crystal eyeglasses, but they're called Amblis, but they are $450 for a pair. Of course, studies have shown better compliance, and the filter in the fellow alternates between opaque and clear. And the prospective studies suggest equal efficacy to patching, but these, I think, are out of reach of most of Indian children. Acupuncture has been studied in anisometropic amblyopia, but it's hard to say how this can be used in our scenario. Physical therapy, this was something amusing, actually. Short-term occlusion of the amblyopic eye combined with physical exercise, such as cycling. After 6 brief training sessions, visual acuity improved in all the 10 patients, and 6 of them also recovered stereopsis. The improvement was preserved for up to 1 year after training. This was a study that came out of Italy. So they proposed a non-invasive therapeutic strategy for adult human amblyopia based on inverse occlusion and physical exercise procedure. Let's move on quickly to pharmacotherapy. You're all familiar with dopamine, which has been found to be reduced in the retina in deprivation amblyopia. And so increasing level of dopamine in the retina has received a lot of interest. And levodopa and acetylcholine, I think most are familiar with, that is old news. This is another study with donepezil, and this donepezil is a medication that is used for suppression. And this trial closed in January of 2021, and this is particularly used for residual amblyopia, and so we will wait for the results. In 2019, another study, which is citalopram, using citalopram, which is an anti-anxiety, antidepressant medication, where they combined patching and citalopram on visual acuity in adults with amblyopia, headed by Benjamin Thompson Group, again, a very famous researcher in the area of amblyopia, found that there was a definite improvement using this medication. And the most recent one I found was subanesthetic ketamine, which reactivates adult cortical plasticity to restore vision from amblyopia. I think the initial studies have really come out in mice. We don't have results in human subjects as yet. For those of you who are interested in reading about these and others, I suggest Emerging Therapies for Amblyopia in Seminars in Ophthalmology, published earlier this year by David Hunter and group, an excellent tome for the study on amblyopia. In conclusion, technology has a big role to play in amblyopia treatment today and possibly in the future. And this is a fascinating area of research, and it will help both adults and children. I thank you once again for your patient hearing, and I particularly thank TOS, Dr. Santosh, and Dr. Asha, who extended the invitation to me. Thank you.
Thank you so much, ma'am. That was such an informative talk. So many new things to learn. I hope to use some of them in the near future. We can take the comments after the last talk, ma'am.
Thank you so much, Dr. Meenakshi, for the wonderful talk. Moving on, I would now like to invite Dr. Asha Samdani for her presentation. The topic is adjustable surgeries in strabismus surgery.
A very good afternoon, everyone. I'll try to keep my talk short. I will make you go through a brief talk on adjustable sutures and strabismus surgery. First of all, what is the principle of strabismus surgery? It is to secure the extraocular muscles to the sclera with a temporary knot or a sliding knot. And then later on, after the anesthesia effect beams off, look for the final adjustment and adjusting the length between the attachment and the scleral attachment. And it can be approached either through a limbal or fornical approach. It can be a two-stage one or a single-stage surgery. In first stage, generally, the muscle is sutured in such a way in which we can vary the recession effect. And in the second stage, the post-adjustment is done within 4 to 24 hours of the surgery. And anesthesia, it's generally, it's a little controversial topic. Anesthesia, in general anesthesia, generally inhalational anesthetists are not advised because patients may not respond properly post-recovery from the anesthesia. So intravenous propofol with combination of nitrous oxide is ideal for the adjustable cases. And in local anesthesia, it can be done either through retrobulbar, peribulbar or subconjunctival route. Here we are going to go through two techniques for the adjustable surgery. In first thing, there is a bow tie technique. In this, as we can see, after the disinsertion of the muscle, there is a single knot for securing the muscle to the sclera, and the second knot is put in a 1.5 knot so that we can open this knot during the post-adjustment stage. The second technique is a sliding nose technique. In this, it's similar to the other one. After disinsertion of the muscle sutures are not directly sutured onto the sclera, but there is another suture involved. This is a sliding nose one, which is tied in a square knot. So this knot can slide over towards the muscle to reduce the amount of recession, or away from the muscle with a counter traction. This will increase the amount of the recession. The another technique is short tag nose technique. This is similar to sliding nose technique, but the ends are cut short. This helps mainly in children in which we think that the adjustment may not be needed in the second stage. And because of the similar thing, it can also help in deferring the adjustment for days post-op. Indications. Generally, it is indicated in complex strabismus cases where you are not sure of the results, or in the cases where the critical correction is very important, such as in previous trauma cases or surgical cases, restrictive disease like thyroid ophthalmopathy, palsy cases, and strabismus with visual defects. In this, the correction becomes very critical. Diplopia following RD surgery and large angle squints. So contraindications, the absolute contraindication becomes the uncooperative patients, and high myopes and tribal thready muscles are the relative contraindications. So I'll just go through some special cases mentioned. In pediatric cases, these days adjustable suture is also being done in pediatric cases. In this, the second stage of surgery is done under topical paracaine with intravenous propofol. And they have seen that there are no complications with this procedure and also improved success rates. Adjustable inferior obliques, adjustable Faden surgery, and adjustable superior obliques are also can be seen. Complications. Generally, the complications are seen during the adjustment phase because we are dealing with the muscles. They may be nausea, oculocardiac reflex, bradycardia, and syncope. And post-operative, generally we expect an increased inflammation, adhesions, and suture granulomas because of the sutures. I'm going to take you through a case of left eye recovered 6 cranial nerve palsy with esotropia. The patient also have bilateral traumatic optic neuropathy with a bitemporal hemianopia. As we can see, he is having a face turn of 10 degrees and also 30 prism diopters of base out. I would like to credit Dr. Pradeep Sharma for this video. So we are initially going with the LR plication. We have planned LR plication beforehand before going for the adjustable surgery of MR. I'm going to skip the LR plication part. So LR plication is finished here. And we have closed the peritomy. We have done a fornix-based approach for the MR. After hooking the MR, we have cauterized any bleeders. Now we are securing the MR at the insertion with the help of 260 Vicryl sutures. Now we are disinserting the MR from the sclera, and the bleeders at the insertion site are cauterized. Now we can see after the muscle sutures are passed through a long scleral tunnels, and then they are secured at the attachment site. Now we have done a hang back of all 6 mm, and we are tying the Vicryl sutures with a 1.5 knot with the silk suture as a stay suture. This helps us in the identification of the sutures. Now a 60 Vicryl suture is passed as a traction suture. This helps us in the, so this is the short end of the MR adjustable suture. This is the longer end. By pulling this, we can release the 1.5 knot. And this is the silk suture. This helps in keeping the sutures apart. And this is the traction suture. This helps us in giving the counter traction. After this, we are closing the peritomy and the sutures are placed in the side. Now, after we wait for 4 hours for the anesthesia effect to pass away, we have examined the patient and he complains of a lip diplopia. So now we have planned to adjust the MR incision to 3.5 mm from 6 mm. So how exactly do we plan the second stage? In the following video, let's see how to adjust the sutures after medial rectus recession. The identification of the following sutures is important, which will be dealt in detail in the following video. The eye is adequately anesthetized with the help of topical anesthesia. Our first step will be identify the traction suture, that is the suture with the loop with knot. With the help of 2 forceps, identify both the ends of the adjustable suture. Pull the short end completely and pull the silk suture to release the same. Now pull the both ends to tighten and put a 1.5 knot to secure the same. After putting the knot, the patient is checked for the resolution of diplopia, and after confirmation of the same, we can cut the silk suture and secure the 1.5 knot with 1 more knot. Then trim the sutures. The traction suture is also cut and the conjunctiva is reposited. Thank you for your patient listening. In the following. So this is the post-op of the patient. Now we can see he is orthotropic in the primary gaze and there is no head turn, and the diplopia is also resolved. Some future directions in adjustable surgeries can be using barriers like silicone, viscoelastics, bioreabsorbable films, or mitomycin. This can help in delaying the second stage so that we to prevent the formation of adhesions. And resections and transpositions can also be thought of. I would like to thank TOS, Dr. Santosh and Dr. Pradeep Sharma for giving me this opportunity and making me a part of this journey. Thank you so much.
That was really wonderful, Dr. Asha. It was a pleasure to see that presentation. Very nice, very concise and very clear cut. So I think we can open up for any questions. You can check.
So if we want to have any discussion points, we can have it right now. So we have few questions for the in third cranial palsy. When exactly will we plan fixation, posterior fixation, and globe fixation?
Yeah. So when we have a case in which we have, let's say, the horizontal deviations corrected, and we are left with some vertical deviation which the patient wants to be corrected. Usually in the third nerve palsy cases, we do not have much option of operating on the vertical recti if both are involved. If one of them is involved, like it's an inferior division problem, then probably you can do a superior rectus recession or the reverse. But if both, it's a complete third nerve palsy, and you do have a vertical deviation, the only way to correct the vertical deviation would be to operate on the other eye. So in the contralateral eye, you can do a inferior rectus recession or just inferior rectus Farden and a superior rectus Farden to prevent the vertical deviations in the good eye, so that we can increase the field of binocular vision. So that is one option which is available, like I had shown in the case 4, that girl in which there was a large hypotropia of the right eye, and I had done the superior rectus recession with Farden on the other eye, the left eye. So that is one thing which we can do, the Farden in the other eye, to improve the fields of binocular vision. The other thing was, what was the other part? That posterior fixation in periosteal fixation, you said.
Yes, sir. Periosteal fixation.
And third nerve palsies, as I had shown in severe cases of third nerve palsy, when there is a large exotropia and the lateral recti have very tight muscles because of long-standing third nerve palsy. So in these cases, it's very difficult to do any procedure on the lateral rectus. Even periosteal fixation may not be that easy, but you can do the periosteal fixation of the lateral rectus to take away the exo force. But still, if the eye is exo, what do you do? For such cases, we do the periosteal fixation of the globe to the medial periosteum, so that the eye can come in the primary position. So this is done using non-absorbable sutures and fixing the globe to the medial periosteum. I think there is a video available on the YouTube on my channel. If somebody is interested, that can be seen.
Thank you, sir. Can I request Dr. Bevira and Dr. Meenakshi to add some valuable comments on this regarding the management of?
Yeah, I think the Farden procedure on the contralateral muscles is basically to kind of enhance the field of binocular vision, especially with the inferior branch, the inferior rectus is involved, so the down gaze problem. So you could actually collapse it, increase the field in the down by doing the contralateral inferior rectus Farden. And I fully agree with Sir Pradeep Sharma sir about what needs to be done in those cases. Apart from that, I think I haven't done much about the globe fixation to the periosteum medially. Of late, I've done a few cases of lateral rectus split, split ends of lateral rectus to the medial rectus, transposition to the medial rectus, and it does work well. But the only problem is I don't put those arms way back as it was described in the original article, but I just slide them under the superior and the inferior recti, and then suture it close to the medial rectus. And sometimes you could enhance it with medial rectus resection to hold the globe. And then for the hypo element, you could do contralateral surgery. So I think third nerve is a difficult entity, basically. So what you're looking at would be primary position deviation in the down gaze, and basically to enhance the field of vision, binocular vision.
Can I have Dr. Meenakshi to add about loop fixation?
Yeah, I think inferior rectus Scott's procedure also works well, but it's not perhaps as powerful as a Farden. And then there is always a concern if you adjust it, or if you do an adjustable Scots or hang it back, that there will not be a good addition between the inferior rectus and the globe. So these concerns are there. I have had luck with just a couple of patients. I don't have the experience of Dr. Pradeep Sharma. I was only going to ask Dr. Pradeep Sharma another question. I recently had a patient who had a widening of the palpebral fissure on adduction as an aberrant regeneration. Parent is absolutely refusing to let me operate on the other eye. How do you convince patients to do that?
I think you need to explain to them the options that are there. And if they are convinced of this problem, that this can be corrected. Now, this you have to show to them that when the eye is coming in this position, the lids will be, corrected to the normal position. And in fact, there is a nice paper which I think with Shweta Chaurasia we had done to see how much of this other eye surgery should we do, so we can quantify it. So what you need to show to the patients is with the prisms, by on the good eye, using the prisms and showing that how the ptosis gets corrected as you are moving on this side. So you say that, look, we are correcting the other eye and this is getting corrected. So this is how the surgery will work. So a demonstration should probably counsel them, I hope.
Yeah.
So how does it work out on the operating on the same eye? Let's say, if the medial rectus function is 0, then we won't really resect the medial. But if some amount of medial rectus function is there, and then you do a R&R and the ipsilateral eye, that would also take care of the aberrant regeneration ptosis to a greater extent. I really don't know. I haven't compared with the other eye and this eye.
No, not really, because you see here the innervation is going to the LPS.
Correct. Yeah.
Like one case I had shown in which the exo wasn't there.
Right.
But only the LPS having an aberrant regeneration. So sometimes we have a situation in which the exo is not there in the primary position. Then you won't be doing obviously the R&R. In that case, something like a Scott procedure on the lateral rectus or a Farden.
Right.
Now, what you are saying is that if you have a situation
exotropia,
only the lid problems are there.
Okay.
Then that is only going to work with that.
Okay. Okay.
Surgery, if you do it, actually works reverse. Because if you strengthen the medial rectus, the infusion required for the medial rectus will be reduced.
Right.
So the lifting of the lid also will be reduced. You get me?
Right. I got it. Yeah. Yeah.
That will be required, because if you are strengthening the medial rectus, then the required to the same medial rectus will be less, and that innervation was going to the LPS, so it will not correct. So it has to be on the other eye, which will work like a fixation duress.
Right. Yeah.
Impulsively.
Thank you, sir. I would like to ask Dr. Rashman and Dr. Clement if they want to add anything.
Okay.
Dr. Asha, are there any other questions?
Yes, ma'am. We have still time left, 2 minutes, so I think we can go ahead with one more question. Sir, what is your opinion regarding the age to be operated in IDS? Like it has been mentioned, 4 years. Can it be done before?
Yes, it can be done. If the control is poor and if the noticeability of the deviation is quite a bit, and you see in the clinic itself when you're checking the patient, if let's say a 3-year-old child is sitting in your clinic and when if you're looking for a distance, the eyes are out, even if before even you have done a cover test or an alternate cover test, that means the control is very poor. So in that kind of a scenario, you can operate earlier than 4 years. But basically, if you have to get good amount of measurement of the deviation. So the age factor of 4 years and lesser than 4 years is basically we are trying to create a small angle esotropia post-operatively. So these patients, some of these patients, if your deviation measurements are not okay, you might create a a kind of a monocular kind of monofixation kind of a syndrome because of the secondary esotropia, and they might go up, they might become amblyopic, and they can go into amblyopia, loss of stereopsis. But having said that, you can operate less than 4 years. But if you're pretty sure that the control is poor and deviations measurement is good enough for you, you could operate.
Correct. So I think age is the secondary thing. Main thing is the control, which is losing the binocular vision and stereopsis. So even though amblyopia is rare in exotropias, the loss of binocular vision is as bad as in esotropia. So if there is a manifest exotropia, it will be risk to binocular vision. So if that is there, then you may do a surgery earlier. But yes, considering the age is less than 4, I would do an undercorrection so that I'll leave a little bit of exo, which can be controlled by his efforts. And later on, we may do a more definitive surgery.
Yeah, so I would, yeah, that's right. I mean, that's a way of kind of, keeping off, creating a monocular esotropia, danger of creating a monocular esotropia. Yeah.
I think our time is up. I would the organizers US for a wonderful feast that they provided, many ways than just the scientific gathering. And thank you very much. Thank you, Asha. Thank you, Diksha, and thank you all the panelists. Thank you.
Very insightful and comprehensive talks by all our speakers, and very well moderated by Dr. Asha. Thank you, Dr. Pradeep and Dr. Rao, for chairing the session.